So first and foremost, I'd like to welcome Professor Frances Rice. Professor Rice is going to be presenting on school interventions, and for those of you who don't know her, she's the co-director of the Wolfson Centre for Young People's Mental Health at Cardiff University, a development which has been so hugely significant for our country and for the work that we're all interested in here this afternoon. So very warm welcome to Professor Rice, and I'm going to hand straight over to you. So thank you very much.
Thank you. Good afternoon, everyone. So I am going to try and give a very brief overview of the current scientific evidence around school-based interventions to support young people's mental health. It's a very sort of large and complex literature, so I'm going to take a very particular perspective. So I'm going to take a scientific perspective, summarise the scientific literature briefly, and try and give an overview of some of the key lessons that can be learned from that scientific literature. And I am going to focus on reviewing two types of different perspective, if you like. The first on interventions that aim to reduce emotional problems in young people, so specifically anxiety and depression. And then the second on interventions that aim to promote a more positive school culture, and in so doing have beneficial effects on health and health behaviours. So just in terms of some definitions and outcomes, so the evidence that I'm going to review today really briefly, much of it focuses on mental health problems as an outcome. So these are clearly things that exist on a spectrum, so from mild to moderate and severe. There are different, if you like, classes or categories of these difficulties. I'm going to focus in particular on anxiety and depression, which I'm calling emotional problems today. And these difficulties can exist, not only vary in severity, but they can persist and cause significant distress to young people, their families, and also affect functioning in everyday life, such as learning at school. And at that point, when someone's had difficulties that are persistent and cause distress and impairment, we call that a mental health disorder. This is some data from an English survey of young people in 2017 and 2020. And we know that mental health problems, so this is probable mental health disorders, are really pretty common in children and young people. So in 2017, estimates were that around 1 in 10 children and young people was affected by a mental health disorder that caused distress and impairment. And then, you know, unfortunately, during the pandemic, this does seem to have had an adverse effect on young people's mental health, with this rate rising to around 1 in 6 during 2020. And like physical health problems, we know that mental health problems are more common in particular groups of young people. So there's a socioeconomic gradient where these types of difficulties tend to be more common in children from poorer families, in children who have additional needs, so additional learning needs, who may have neurodevelopmental problems like ADHD and autism, as well as young people who've experienced early adversity. So these are difficulties that tend to be more common in particular groups of young people. And so, as we've really heard in the introductory statements this morning, there's been a lot of interest in how school can be a context to deliver interventions to support young people's mental health. And broadly speaking, the evidence that I'm going to summarise today falls into what we might call prevention approaches. And so there are different types of strategies that can be used. These preventive interventions can be delivered universally to sort of all young people in a particular population, say for instance a particular year group, irrespective of the characteristics of those young people, or they can be targeted and if you like, selected to be delivered to young people who are thought to be particularly more vulnerable to developing these difficulties. So targeted preventive interventions are typically delivered to young people who've got risk factors that we know make them more vulnerable. For instance, children who are in low income areas or have got additional family risks, or they can be what's called indicated. So where you might target, for instance, an anxiety prevention programme to those young people who already have slightly elevated but subthreshold anxiety symptoms. And these sorts of interventions, I guess, broadly speaking, can be separated into mental health problem prevention programmes, and I'm going to focus on emotional difficulties, and health promotion programmes, which might aim to bring about systemic changes in the school system that hopefully has beneficial effects on a range of outcomes. So in terms of the literature around anxiety and depression prevention programmes, there's a really rich scientific literature. There's well over 100 randomised controlled trials, and these have been summarised in lots of systematic reviews, including a really recent one. The vast majority of the types of programmes that aim to reduce symptoms of anxiety and depression in young people, as well as the aim to reduce the onset of depressive and anxiety disorders, are based on the principles of cognitive behavioural therapy. So that involves things like teaching young people skills around identifying and challenging negative ways of thinking, trying to help them to develop ways of solving problems more effectively, as well as giving good quality information about what anxiety and depression are. These types of programmes tend to be delivered in classroom time during school time, and they tend to last for around 8 to 12 weeks and be delivered in sort of weekly sessions. And what the systematic reviews and sort of meta-analyses show, when you put all that data together, are that there are small but real beneficial effects on rates of depressive symptoms and anxiety symptoms. So for depression, what the evidence shows is that the type of approach where you target an intervention at young people who have risk factors or early symptoms is more effective than when you deliver that intervention to all young people, regardless of their underlying overall sort of risk. For anxiety, though, there is evidence that a universal approach, so delivering to all young people, is associated with benefits. Also, for depression, there's some evidence to suggest that you get better or greater benefits when the intervention is delivered by an external health provider rather than by a teacher. So what are the things that we sort of either don't know yet, or are kind of remaining questions and areas of where the evidence can be built? So the first thing really around anxiety and depression prevention programmes is that we see a drop-off in the benefits in the longer term. So with most interventions not showing beneficial effects beyond 12 months, though there are a few notable exceptions to that. And so that creates the question of whether we really need to be giving people booster sessions to sort of help keep these skills and these benefits going for longer. The other general finding is that findings are variable across different studies and across different populations. And with all research, that is, you know, to some extent exactly what you would expect. And there are a range of reasons for this. So the first is around the quality of the delivery of the intervention and how much it is the intervention that was intended to be delivered. The other is really around the population and the age group under study. So particularly for depression, for instance, there's been a real focus of studies on secondary school age pupils 14 and over. And so there's less known about how effective the intervention might be in younger populations. The other things that we don't know yet and will need further research on are there are particular groups that we know are vulnerable to developing anxiety and depression, such as children with additional learning needs. And the possibility of either adapting content or sort of modifying the approach for delivering interventions to prevent anxiety and depression in these groups hasn't been well studied to date. The other sort of limitation of this type of evidence is that it's very focused on one particular outcome. And so, for instance, you may find that benefits for anxiety, for instance, don't replicate for other types of outcomes. And one sort of interesting potential question for the future, because we know that there's a really strong relationship between earlier anxiety and later depression. One possibility for future research is to consider whether reducing anxiety earlier on could potentially have beneficial effects on later depression, and that's not currently known. So next I'll move on to some studies around the school environment. So there's lots and lots of scientific evidence to show that the climate of a school, including things like school leadership, relationships between teachers and children and between peers, has really important implications for young people's development and health, including their mental health. And probably the first sort of scientific observations on this go back to the late 70s by Mae'r Athro and colleagues. And there's very good evidence that how students feel about their school, how connected they feel to their school, do they feel accepted, valued and respected and included in their school environment, that has protective effects on a really wide range of health risk behaviours, including anxiety and depression, suicidal thoughts, use of drug and alcohol, violence and so on. And so this feeling that young people have of how connected to their school can be very important for their health, including their mental health and their well-being. And so that's led to a real interest in interventions that seek to improve student engagement with school, that being sort of an important social determinant of health. And it's led to things like the health promoting school framework set up by the World Health Organization. That said, we know that school isn't always a safe place for young people to study and grow, and in particular it can be an important context for exposure to things like victimisation, which we know then has enduring effects on health. So next I'm going to describe two really landmark studies that were published a few years ago now in the Lancet that focus on improving school climate. So one based in India and one based in the UK. And so I'll start with a study from India first. It's called the Seher intervention, and it's a multi-component health promotion programme. So it involved activities at the whole school, the classroom and the individual level. And it aimed to do four main things. So it aimed to promote social skills in young people, enhance problem-solving skills in young people, provide access to factual information about health to young people, but also crucially to engage the school community in decision making. So to really involve students and give them agency over the decisions that got made in school. It's a really, really large randomised controlled trial. So there's well over 13,000 young people. So it started in grade 9, so when pupils were aged 13 to 14, and the data here are across an academic year. So the intervention was either delivered by a teacher or by a lay counsellor, and that was then compared to usual school provision. And the two really quite remarkable things about this intervention. So the first is that it showed beneficial effects on a really wide range of outcomes: school climate, depression, bullying, violence, victimisation and perpetration, attitudes toward gender equality and knowledge of reproductive and sexual health. The size of these effects was moderate to large, so the benefits were moderate to large. That's quite unusual to find, large effects in a study of this kind, where we know we're looking at complex sort of outcomes. The other really striking thing about this intervention is that it was only effective when delivered by a lay counsellor and not when delivered by a teacher. So then
sorry, Frances, just to say, just a few minutes left, I'm afraid.
So the UK intervention is the Learning Together intervention. It's a similar type of programme, so it's a health promotion programme, and it involved a school action group, so just enhancing decision making, staff training in restorative practice, and a social and emotional skills curriculum. It was a longer study, so across 3 years, and it showed beneficial, real, significant but small effects on bullying, mental health and quality of life. So I need to wrap up quickly. So in conclusion, school climate really looks like a promising target for improving well-being, symptoms of mental health difficulties and risky health behaviours, but it takes time to embed that systemic change and to implement it into practice. It's also relatively cheap to deliver. One observation in lots of these studies is that interventions were not always as effective when delivered by teachers, and there are likely a range of complex reasons for this. Probably, most importantly, to do with workload and additional capacity in the system to meet the additional requirements of teachers, but also around clarity of leadership for health promotion and not having to switch roles between pedagogy and other activities. Some interventions are complicated as well, and so you may need specific expertise. So just to summarise, this is a really complex area with multiple and sometimes conflicting findings. There's a disconnect between the interventions that are available for people to use and those that are supported by evidence. And Public Health Wales has set up an expert review process to help with that. I'm going to sort of finish off quickly to allow some time for questions, but really outstanding questions around what's the appropriate balance between universal and more targeted provision, and also the need to consider factors outside the school as well as external support that's available where needed. So with that, I will say thank you very much for your attention, and I just want to acknowledge Olga, who's helped with the slides.
Thank you so much, Frances, and there's so much to cram into such a short time. And we do have a couple of questions in the sidebar. That was a really fascinating presentation, and I know that we may not have time for you to respond verbally to them all, but I just wondered if you would be able to put some commentary in the sidebar for us, Frances. So
sure.
The first question is from Jane Reed. How does the increased benefits by an external healthcare provider contrast with reports that young people prefer a known and trusted adult, such as a teacher? Perhaps if we could take that one verbally, I can cover the other two in the side.
Yeah, I mean, it does. And I suppose the key thing is we are thinking about exactly what teachers are being asked to do, which will be different in a randomised control research context where they're having to deliver something that is very sort of structured versus perhaps more flexible support. And probably, I would say that the particular value of teachers may be in supporting some of these more kind of circumscribed and manualised in type of interventions.